Hello, good morning, and thank you for the kind invitation. It's a true honor to be here. And my last name is Leite, as I was this morning, so that'll make it easier for all of you to remember. I'm very happy to be able to share a few views of what I consider should be the driving forces of transforming and reforming health systems, and how that then influenced action in my role personally at the local level as a deputy mayor of a mid-sized city with 200,000 inhabitants, 20 kilometers from Lisbon. So this is where I'm from. So Washington's nice, but we have a pretty good life out there, as you can see. So we're all familiar with the Industrial Revolution and how it transformed our lives in many aspects positively. And it very much influences what we're doing today. And we can see, for example, the way we make cars. We're pretty much doing the same Henry Ford was doing more than 100 years ago. But the truth is, back in the 70s and 80s, business schools started looking at these car building factories, especially in Japan, and started looking at these governance models or management models, if you will, and transforming them and trying to adapt them to health sector that were considered to be poorly managed mainly by doctors, by physicians. And that led to something I like to call the industrialization of healthcare. The belief, the dogma, if you will, that the more we produce, the more efficiently we produce, the better health outcomes we will get. Well, we all know what happened from there on. We ended up with a rise of burden of disease and a rise of costs. This, of course, leads to risks of unsustainability and can compromise our aim, our universal aim through the SDGs of achieving universal health coverage. With worse health, everyone will suffer, but mainly the most vulnerable populations. And of course, this ends up in a vicious cycle generating inequalities, inequities, and poverty. And that's why we heard in the previous session talk about Porter, and I think that very much influenced Porter of rethinking a health system and saying that basically in healthcare, days of business as usual are over. And in his diagnosis, I would agree with that. You know, when we look at demographic pressure, raising costs due to technology and innovation, social inequities, chronic diseases, the need for more qualified workers, the raise of the burden of disease, all of these make us need to think of new ways to move forward. So I'm very ashamed that I'm at the National's Academies and I'm showing a cartoon, but I speak with politicians and it makes it easier to get the message through. And the truth is, we, in our current hospitals, we've made them factories of production. And we've put the carrot as the incentive, which can be financial or of other nature. And the more surgeries that we do, the more money they get, or whatever incentive we've created, the more hospital visits, the more emergency room visits. And that has led to that rise of disease, burden of disease and costs. And what the value-based agenda is saying, that we shouldn't put the carrot where the patient is, focusing on health outcomes, on patient experience, creating incentives for what matters to the patient within the health system. And we do know that pay for performance does work. This is from Portugal, actually. And we can see we actually have half of our primary healthcare clinics with family doctors are run on a pay for performance kind of model. And the other half are run with just a basic salary for all doctors, no matter what the outcomes are. And we can see that when we have a pay for performance, the results, and we have two examples here on hypertension and diabetes, which I think is a great segue from the previous session, the results are double the number of controlled patients in comparison to when there is no incentive. So, of course, creating incentives, if the indicators are right and the way we collect the data is right, can actually work, but it may not be enough. Well, so to make it simple, if you look at UCSP, the first column there, those are the clinics that there is no pay for performance. So it's the model where people get a salary no matter what they do. USFB is the most advanced family health unit model in which the team is, so doctors, nurses, and the rest of the staff are financially incentivized based on a set of audited indicators. All right? And that's why I say it's double. And the number of controlled patients with diabetes and hypertension. But I was saying, this may not be enough. Look at this graph here. We can see on the x-axis the cost of care, and on the y-axis health outcomes. And it's no surprise, especially in low and middle income countries, the more money you pour into health, the better the outcomes. And it's pretty much true throughout Europe and all the way up to Singapore, well, probably one of the most efficient health systems out there. But then a curious phenomenon happens. The more money you pour on health systems, there's just a plateau. It doesn't continue to grow. And it kind of dips when we come to this side of the Atlantic, to the US. What I believe value-based healthcare will do is create this line here. It'll push the curve up, but it'll plateau anyway, because it continues to focus within the health system, within a system that is already dealing with the disease after the disease is installed, is present. So the great question here is, how do we create this third line? How are we capable of generating more and better outcomes in the future without compromising the sustainability of our health systems? Well, to deal with that, I think we need to understand what composes our health status. And we know that as a physician, when I have a patient in front of me in the clinic, I'm only looking at probably 10% of what is conditioning that person's health. 30% is probably from biological factors, in which we can include genetic factors, and 60% on the economic, the environmental, the social, the behavioral factors. And the truth is, we are only normally dealing within the health systems, we are only dealing with the 10%. And that's why looking at the determinants of health, social and others, is so important. Understanding how housing, how agriculture, how water and sanitation, all of these basic things, jobs, employment, work conditions, all of these things actually influence our basic health outcomes. And that's why I would argue that we can actually use the value principle, but we need to take it a step further and get that carrot outside of what we formerly called the health system and put the carrot in the middle of the community, of what I like to call the community value-based health system, in which we should have a management focusing on the territorial level instead of focusing on hospitals and clinics, and being able, at that level, to establish all of the needed partnership with all of the needed partners, with City Hall, with the education system, with the private sector, with the social sector, with NGOs, to be able to focus on what I'd like to call the CBOMs, the community-based outcome measurements. So instead of just focusing on controlling diabetes or hypertension, we can actually create incentives towards lowering the incidence and prevalence of hypertension and diabetes. It is my firm belief that we will not be able to continue, we will not be able to see public health be part of the mainstream discussions, both in politics and in the health field, if we don't make public health part of the financial system as a whole in health systems. Or else, public health will always be seen as a side gig that takes less than 3% of health budgets. So this was to lead towards the importance of working at the community level. And I was elected as a deputy mayor in 2015. And it was so this is the city 20 kilometers from Lisbon, by the sea. I showed you the picture, so it's a beautiful beachfront area. But 200,000 people, very close to a capital, is a great place to experiment and to try new things and to see how then we can scale up. And when I was elected, it was 2015, so it was very fortunate because it was the year the SDGs were approved. You all know about the Agenda 21 and 92, and then the Millennium Development Goals that were somehow successful in putting the world pushing in a certain direction. And in 2015, the UN General Assembly decided to approve the 17 goals that compose the Sustainable Development Goals. And these are global goals with a very global framework. The question is, how does this translate to the people that we do not want to leave behind? And Antonio Guterres, who is the former Portuguese Prime Minister and now UN Secretary General, he said a global response is needed, but we need to go from concept to implementation. And I truly believe that we needed to do it at national and also city levels. And that's why we developed this project here, I'm sorry for the busy slide, but it's just to show you how we ended up with this idea of a project we call 2030, Cascais 2030. And basically what we did was, how do we translate these 169 indicators of these 17 SDGs at the local level? And so we started to work with the people on the ground, translating each of those 169 indicators, and listening to citizens, to NGOs, to people in the city, to corporations. And we came up with the translation of these global indicators to the local level. Just as an example, one of the indicators in SDG 3, which is good health, is universal health coverage. For us, at the local level, that means ensuring that every citizen has access to a family doctor. That became our indicator. And so we are, as deputy mayor, as councillors, we're on a board. And every time we submit a proposal now, we do it through a digital portal. And this pops up, it's a mandatory pop-up. And the councillor has to say which goals they are complying to. Then we got a chief sustainability officer that picks up this data and fuels this dashboard. And this dashboard tells us online, so it's keeping the city accountable to all citizens, how the city is doing on each of the 17 SDGs. What is curious, we were the city that won the most awards on climate change and adaptation. And when we did this, we ended up with the worst result out of all of the 17 goals. But you know what? It goes to show, if you don't measure it, you just believe whatever the awards tell you, right? And it's so important. And the way this has influenced is we have the Cascais 2030 local network. So citizens get together on a yearly basis, reviewing what we've done, adapting the different indicators if necessary, moving forward to make sure that we keep on track for 2030. And what for me is the most relevant part of all of this is how this influences the budget year on year. So before the budget discussions, there's a report saying exactly how we're doing on the 17 goals. So as you know, the people who approved the SDGs said that we should not leave anyone behind. To do that, we need to know which goals are lagging behind. And when we know which goals are lagging behind and why, then we can readapt our budgets so that we can push those lagging behind to the average and help make sure that all of the 17 goals are moving in the right direction. And the local network is making sure that these indicators, the work we're doing here, actually translate to people's interests on the ground. A second project that I brought here is the Smart Health Cascais project. It's actually a pretty simple project where we understood that to move forward, we needed to monitor key health, education, and social indicators of the population. The reason I ended up doing this project was because when I got to City Hall, I looked at the millions of euros we were spending with NGOs and basically contracting and subcontracting a whole bunch of services. I said, how are we measuring impact? And everybody, kind of squeezed out of the room and nobody answered. And then I said, okay, let's start thinking how we can measure impact. Oh, tremendous resistance. And in politics, you need to adapt. And I understood I wasn't going to get anywhere. And so I decided to go the other way around. The SDGs was one way. The other way was, okay, let's start monitoring global results at the city level. And then we'll, reverse engineer from those results. And that's what we did. And we geo-referenced all the indicators we could in these three sectors, health, education, and social sectors, at the most local level possible. So we have a 7 zip code level, which gets down to the neighborhood level. And we did this, of course, through partnerships with the people holding the data. Not an easy task. And we ended up with some of them. I'm just bringing 2 examples. Number of patients without family doctors. Of course, this is important to fuel also the SDGs. Or, for example, when we look at, we have electronic prescription of drugs. So we can actually see how many antidepressant and benzodiazepine drugs were prescribed and how many were actually bought by the citizens in the pharmacies. And so when we're talking about local mental health programs, instead of talking generically, we can actually see where there are more patients, and we can start asking the questions. Is there a question of overprescription in certain parts? Are people actually with worse health status in those areas? How can we work towards presenting better results. And building on what we just heard in the previous session, we also had indicators on obesity and diabetes that actually allowed us to redesign our bike lanes to make sure that we're going through the most critical areas. Then crossing, social indicators with educational data and health data to understand where we have pockets of the most vulnerable populations to create special educational programs or special support programs that we could provide to the people. And so it's open access, transparent, and it keeps us all accountable. And once again, it creates an incentive to push people in the right direction. It gives orientation for our action, and it allows us not only to move in the direction of health, but also of well-being, which needs to be the new trend of health systems, but focusing on constant impact and evaluation. So not only data to make a decision, but also getting real-world data as we move along to adapt our decisions, because there's never perfect policy. We need to have that capability to advance. And so the pentagram for change, as I like to call it, involves, of course, politicians and leadership, but we need the scientific community, the healthcare workers. We need media, both conventional but also social. Civil society, critical. We cannot talk about universal health coverage if civil society, if NGOs are not part of it. These movements are the only way, through community-based organizations, to actually reach out to the most vulnerable parts of society. If we do not work with civil society, we will leave people behind, and we will not have true universal coverage. And the private sector is critical. We know that we are unable to fund these SDGs, especially in the low and middle income countries. The estimated cost by the World Bank to achieve the SDGs is up to $3 trillion. In no way in the world will these countries with their own domestic budgets be able to hit the 17 SDGs without the support of all of the different partners on the ground. I know it's overwhelming, but as Mandela said, it always seems impossible until it's done. Thank you very much.